Hello, everyone, and thank you for being here. My name is Jen DiMartino, and I'm the Executive Director of ALS One. ALS One was formed in 2015 to unite ALS research and care. We are a Boston-based nonprofit, and we're very proud to work in partnership to advance pivotal ALS research initiatives towards treatments and ultimately, hopefully, a cure for ALS, while simultaneously working to provide essential equipment and care resources for people living with disease now and their families so that they have the best possible quality of life while navigating the complexities of the disease. This ALS publication research initiative was the brainchild of NEALS, the Northeast ALS Consortium, and their subcommittee, which is entitled their NICE group. It is the NEALS Information and Community Education Working Group, very aptly named for a group of very nice individuals. In it, they identified a gap that existed in linking the ALS community to important ALS publications and the authors to better understand the entirety of those publications at the ALS community level. We were very excited to kick off our inaugural webinar last month. Our webinars we're piloting are going to be a two-pronged approach. Two webinars, 2 separate months that fall under the same umbrella topic. And our first one was under genetic testing. And so our first publication review, which was in May, took a deep dive at the publication entitled Incorporating Genetic Testing into the Care of Patients with ALS FTD Spectrum Disorders. We were very honored to be with two of the authors of that publication, Lauren Lichten and Lainey Dratch, and it was a really wonderful way to ask important questions from the ALS community to gain a better understanding. And on that panel, we had Mandy Bailey, Dr. Justin Kwan, David Schulman with us, and it was really powerful. So today, I am imagining is going to be equally enlivening and enlightening, rather, as we are under the topic of genetic testing as well, but a different realm. This is under guidelines. So what we know now about genetic testing and about sort of the many different genes that are responsible for the familial onset of the disease, and the fact that there are now treatments for some of them, is creating a real important conversation surrounding genetic testing, whether you're known to have a mutation in your family or not. And it's a very heavy conversation. These guidelines were obviously a very collaborative approach by many people. There were 5 authors who collaborated on it: Jennifer Roggenbuck, Brita Eubank, Joshua Wright, Matthew Harms, and Stephen Kolb. And we're really honored today to have 2 of those authors with us, Dr. Matthew Harms and Jennifer Roggenbuck. Dr. Harms is a professor of neurology at Columbia, and Jennifer is a genetic counselor, also professor of neurology at Ohio State University Wexner Medical Center. We are honored, truly honored to have you here with us, along with 3 other panelists who are just phenomenal people. But first, I would love it if we could get just a little bit of a background from Dr. Harms and Jennifer on how you got into the field of ALS, and once in it, your decision to steer towards genetics and genetic counseling, and really the catalyst that helped to drive this important piece of publication. So, Dr. Harms, if you could start.
My name is Matthew Harms, and I'm the Associate Director of the ALS Center at Columbia. And my research interest is in the genetic causation of ALS. So I got my start searching in familial ALS for new ALS genes. And then as the ability to sequence people for cheaper and cheaper made it conceivable to go looking for genes in people who had so-called sporadic ALS, I started applying genetic technologies to that group of patients to try to uncover new genes. And so over the course of the last 15 years, we've been very successful at that. And now we're recognizing that we have to go back and re-ask which genes actually cause ALS and re-ask which mutations in those genes actually contribute to the risk for ALS. And then do what's called genotype-phenotype correlations, where we look for recurring themes in how a specific type of a gene mutation influences the type of ALS that somebody gets or how likely they are to get it. And so that's really what my research focuses on. But that means I deal with a lot of people who have undergone genetic testing or meet people who have not undergone genetic testing. And so that was one of the main motivations from my end for helping out with this group to come up with the guidelines.
Great, thank you. Jennifer?
I'm a genetic counselor by training, and when I joined the Ohio State University Medical Center, I became a part of the ALS multidisciplinary clinic here, and I have brought experience with genetic testing and many other medical specialties, including cancer and pediatrics. And so genetic counselors really are experts in genetic testing and offering genetic risk assessment and education to patients. So when I arrived and began meeting persons with ALS, I did what any genetic counselor would do and provided risk assessments and offered genetic testing. And at that time, this was a service that was really limited to persons with familial ALS, if at all. But with the discovery of the C9 gene in 2011, we can now identify a genetic cause in 10% of all persons with ALS. So for me, coming from a background in rare diseases, that is certainly enough to offer genetic testing, whether or not there's a family history. So I began to study this in our clinic population, try and find out what patients wanted from genetic testing, whether or not they found it useful, and also studied practices amongst neurologists to find out, is there a standard of care? Is there any consistencies, or how can we make this genetic testing service and this genetic counseling service more accessible to every person with ALS? So that's really what drove our interest in providing guidelines to the ALS community. And we wanted to improve patient access, and we also wanted to provide guidance to neurologists in offering testing, particularly for those who may not have trained in an environment where genetic testing was part of care. So we really wanted to make genetic testing accessible for all the different stakeholders in the ALS community.
It's fantastic. It's a heavy topic. It certainly, I would imagine a lot of times as a genetic counselor, there's a crossover between genetic counselor and a family therapist, and there's a lot of emotion, and it's got to be very difficult. So I commend you for tackling this heavy topic. We are joined today by three fantastic women. Very excited to introduce Dr. Christina Fournier. She's the Associate Professor of Neurology at Emory. She also is a member of NEALS and among many other things, part of their NICE working group. We are also joined by Lori Andre, who is a NEALS Research Ambassador, and she is part of the Patient Advocacy Committee at NEALS as well. Thirdly, but not last, is Paula Trefiak. Paula is also a NEALS Research Ambassador, and she is also an International Patient Fellow. Christina, do you maybe want to go first and just a little bit of your background and what brought you here?
Sure. So I co-direct the ALS Center at Emory, and I'm the director of the Atlanta VA ALS Clinic as well, and conduct a lot of clinical research in the ALS population. And the topic of ALS and genetics is just one where we've learned so much in the past few years, and I know it can be hard to keep up. And one thing that we wanted to do with the NICE committee is kind of be a good source of reliable information for hot topics in ALS, and provide, real-time updates of what's out there. And this is a very exciting field. We have two wonderful authors with us today who really are experts at this. And so I'm excited to meet with them today and kind of have them talk more about the guidelines that they drafted, which are really important.
Great, thank you. Lori?
My name is Lori Andre. I live in Chicago, and my husband was diagnosed with ALS in the fall of 2016. I've been advocating for my husband, obviously, but also the rest of the ALS community over the last 7 years. As Jen said, I'm a research ambassador at NEALS. I also sit on a number of patient advisory boards, part of the NICE working group. And I'm particularly interested in this topic is 7 years ago when my husband was diagnosed, there really was no conversation about genetic testing. We actually had to ask for genetic testing, which was just a very sort of broad testing for the known genetic mutations, which my husband didn't have. But then we decided to dig a little deeper and get a complete genomic panel. As it turns out, he does have the genetic mutation, the SQSTM1, which then led us to speak to a genetic counselor and find out really kind of what it really means for our family and future generations. So I'm glad that this is being brought to the community so that they are become better informed and actually have access to and are given a lot more information today as opposed to 7 years ago.
It's a remarkable story, Lori. Incredible. And I really commend you and your husband for taking a deeper dive in really trying to figure out what really could be behind it.
And also just to add to that, we actually had his parents tested as well. And as it turned out, his father also has the same mutation. And the way it presented in his father is with Paget's disease. So his father, who is still living today, who's 92 years old, has Paget's disease. So obviously that's how Brian inherited the mutation.
It is really interesting, and I don't want to get too off topic, but it is interesting because, of the obvious C9 that, can cause a couple other things besides ALS, FTD, in some cases FTD and ALS, in some cases just FTD. So it's all so fascinating. Paula, would you like to give your background?
Yes, I'm Paula Trafiak. I am from Regina, Saskatchewan, which is located in Canada. I'm a person affected by ALS. I started showing signs and symptoms in my 20s, and I have several other cousins who have started showing signs and symptoms in their 20s. And back when I was trying to get tested for ALS, I was told that I was too young to have it. After years of fighting, I was finally diagnosed with ALS at the age of 34 in 2016. And I'm affected by the SOD1 variation, and I'm very fortunate that my diagnosis led to me participating in a clinical trial that has been successful. I've actually experienced some disease reversal, not complete, and that is why I'm still alive today.
That's a lot. That's first of all, to have had symptoms. When you had symptoms, were you aware at the time that others in your family had been impacted, or was that new to you?
Yes, so I had already seen 20 some members of my family being affected by ALS and had already passed away. In fact, when I was starting to show signs and symptoms, my dad was in the late stages. So that was really hard, right? And then I kind of brushed my symptoms off at the time as probably just due to stress. And it wasn't until almost a year after my dad passed away where it was like, okay, you know what? This isn't just normal symptoms anymore. I'm pretty sure this is ALS. And, you know, trying to go to my doctor and bring that topic up. And as an athlete, they would just do the regular testing and tell, with, muscle strength and say, but you're still strong. It can't be ALS. You're too young. This is like an old man's disease. So, you've got years before you have to worry about it.
It's such a dated narrative, I feel like right now. And
yeah,
I'm sorry you had to go through that. Yeah.
And we found out now, like I've had my cousins get tested. I've encouraged them to get tested. And I have had several who were tested, hoping to get on the ATLAS trial for pre-symptomatic ALS. And it turned out they were already symptomatic at 21 years.
Yeah.
So, yeah.
I again, just want to say, I admire so much your strength and Lori's for, picking up a baton that's very heavy and just a lot, and you're picking it up and for your family, for yourself, for your family, for your children, for everybody involved. And it cannot be easy. So I commend you for that. We have a lot of questions. We all took a real deep dive into these guidelines, really incredible. And so I think what we'll do is start with Christina and Matt and Jennifer, however you want to field them. If you want to both chime in or field them together, it's entirely up to you. Very casual and just round robin, but we'll start with Christina.
Great. So I guess let's dive right into what I think is one of the key take-home points of your guidelines. So who should be offered genetic testing in terms of patients with ALS?
So our guidelines recommend that any person who has a clinical diagnosis of ALS should be offered comprehensive genetic testing. So what that means is anyone who's seen a neurologist and been told that they meet criteria for ALS is a candidate for testing. And whether or not they have testing is a personal choice. But if they do elect to have testing, it should be complete and look for all the genes that we have that we've identified as being strongly associated with ALS. And as Matt referenced, some genes have been identified as risk factors, or maybe there's some preliminary evidence that they cause ALS. Those genes should not be those genes should not be included in clinical testing until they're validated. There is a separate effort to actually define what ALS genes are that we've referenced in the paper. But the bottom line is that everyone with ALS should be offered genetic testing.
Okay, and so I'm going to go a little out of my original order, because what I think comes after that is, so if everybody with ALS should be offered genetic testing, what needs to be discussed kind of by the genetic counselor or the clinician before that testing is done? Like what kind of conversation should happen in the clinic prior to testing? Because there's a lot of implications and considerations, and this is so common now. I think the broader clinical community now is having some of these conversations and needs guidance on what they should discuss in advance.
Right. So you're basically asking what should genetic counseling for persons with ALS include before testing and after testing? And we really tried to be systematic about that in doing our research and creating our guidelines, which basically provide a checklist. These are the types of activities and conversations that should happen ahead of time. That includes family history taking, which can enable the clinician or genetic counselor to provide some risk assessment of what's the chance that we might actually find a genetic cause in your family? And then just some basic education about what we know about the genetics of ALS. It's, including things like it doesn't always run in the family. It's not always genetic, but when it is, there can be one of many different genes that is responsible. And those genes may or may not manifest in a person's lifetime. And then also discussing personal and family risks and considerations. So it's not just about science. There's also some preparation that these results are important for you, but should you test positive, there might be, significant implications for your family members, close family members, and more extended family members. And people who are considering testing really need to know that in advance. So those types of things fall under the pre-test counseling category. And then on the back end, after testing, we also have summarized a checklist for the conversations that should happen on the back end. What does a positive result mean? What does a negative result mean? And what are the corresponding implications for family members in each of those cases? It's also important for persons to know that it's possible to get an uncertain result with genetic testing, and many people are not prepared for that as part of medical testing. They come to a medical test thinking this is going to be a yes or no answer. It's going to be black or white. And it's important to convey that it is possible to get an uncertain result and what that means. So it's a lot, and we recognize that. And this was the most lengthy set of recommendations in our guidelines paper, but I encourage people to refer to the tables that summarize the guidelines, which really can be used as a checklist to guide a conversation. If you're a neurologist or a patient, these are the things that we should talk about before and after.
And I think the important factor in that is that we wanted non-genetic counselors to be able to provide some of these conversations as well. This is not like ordering a CBC or like a standard blood test. And I think there's a temptation amongst neurologists to kind of present it that way. Hey, genetic testing, we're just going to draw your blood, sign here. And we really wanted to slow non-genetic counselors down to like really put something in front of them that they could work their way through to make sure that they covered all of the important things that should take place in a pre-test counseling session and in a post-test counseling session to make sure that things didn't get missed in the circumstances where a genetic counselor isn't available. Lots of centers don't have ready access to genetic counselors to do the genetic counseling, but we wanted to emphasize that genetic counseling can be done by physicians, nurse practitioners, people who have, invested the time to kind of learn what should be in one of those good conversations. And so that's why we took that lengthy section and distilled it down into a checklist that someone as simple as me could follow. So.
But I think that's a great point, because ideally every person with ALS could meet with a genetic counselor, but there's just not enough, right? And now that we're recommending every person with ALS is offered genetic testing, we need more clinicians to be comfortable having these appropriate conversations, right? So I think that's great that you put it in a checklist form, so it kind of opens up the scope of appropriate genetic testing to different clinicians. So
yeah, and you could even imagine as a patient or a caregiver going into a clinic visit with that checklist, and if the doctor's rushing, saying, "Yeah, but what about penetrance? Yeah, but what about my personal risk?" And kind of like asking for information if the clinician kind of was skipping over some of those steps.
Good point. Okay, I'm going to switch gears a little bit. So I know it's not always intuitive. So each of the guidelines in your paper has a level of evidence. And on first glance, some of these guidelines might be really important, but the level of evidence isn't as high. So it's not actually referring to how important the guideline is, but I thought maybe you could explain like what these levels of evidence are and how they were determined. So it's more understandable to people who might be reading your paper for the first time.
Yeah, that's a very good point, Christina. The level of evidence does not correlate very well with the importance of each of those recommendations, right? So each recommendation that's there, we felt was an important statement as a group to make. Whether the level of evidence was high, moderate, limited, or maybe even just expert opinion. So when you're doing a set of guidelines, there are some pre-specified levels of evidence that everyone uses when putting together guidelines. And you basically want to put those levels of evidence so that people know how strong the data is to support that recommendation. Sometimes there's no data, right? Many of the aspects of the genetic counseling visit, like what should be in that, hasn't been studied in a scientific, fashion. No one's said, okay, you get good genetic counseling and you get bad genetic counseling, and let's see what the outcomes look like. So there's no randomized controlled trial or experiment to show that good genetic counseling is better than bad genetic counseling. So you end up giving something like that an expert opinion type of recommendation because it doesn't have a randomized controlled trial to prove that it's an important thing to do or that it's a good thing to do. So we started off with the world's literature on ALS. We looked up every article that had ALS or amyotrophic lateral sclerosis with genetic in either the title or the abstract. We ended up with close to 30,000 articles at the beginning, and then we went through those using some other search terms to narrow it down and ended up with thousands, and then in the next level, hundreds. And then we read every single one of those papers and extracted all of the information. And so, there might be a paper that looked in 50 people for mutations in gene X. That's a very small number of people. Maybe they only looked for that gene and not for all of the genes. So you went through and we categorized each paper as to whether it was an amazing paper that checked all of the boxes and looked at all of the factors and did it in a large number of people. And then within each recommendation, you kind of add up how many great papers are there, how many not so great papers are there, how many in-between papers are there, and then that kind of gets synthesized into the overall level of evidence. It's a standardized way of doing things. We followed the rules so that it would be generally applicable and acceptable in the scientific community. And that's how we ended up with those levels of evidence, which by and large are going to be important to people doing future studies. Like when you look in the recommendations and you see that something has an expert opinion recommendation evidence level, that's a point where we need to focus some research efforts to actually nail down scientifically so that we're verifying whether our expert opinions are in fact scientifically valid. So that's one of the reasons for the levels of evidence, is to really guide next steps in research around these questions.
Great, I think that helps a lot. Let me hand it off to Lori. What questions did you have from the article?
Thanks, Christine, and thanks for that explanation. That was really helpful. At one point in the publication, you raised the issue that genetic testing should become sort of standard of care. So I'm just sort of curious, like, do you, as physicians, as geneticists, have any strategies for that so that it does become more standard of care? Like, how are you going to deal with that?
Yeah, that's a really good question. One of the issues that hasn't been such a big deal for the ALS community for the last few years is the cost and coverage for genetic testing, right? When I first started doing this, if you wanted to do an ALS gene panel, you'd have to do it at one company because it was only offered by one, and it would be $16,000. And no insurance company was covering it, right? And the costs have come down, but they're still not zero. And thankfully, at this moment, there are a couple of different options for free testing in the United States, but that may not always be the case. And so one of the main reasons for motivating us to come up with these guidelines and to discuss how it should be standard of care is so that insurance companies would have to cover it when there isn't a free test option. And so if it's a standard of care recommendation, then there's very little wiggle room for an insurance company to deny coverage for a test, and hopefully means that in the future we won't have to wrestle with that particular issue. Then I think it gets to an educational setup, right? And basically, if you're a neurologist who trained in the pre-genomic era, you didn't take classes in medical school about genetic testing and advanced gene panels and interpreting the variations that come from it. And so it can be daunting and a little scary to think about ordering a panel and having a 20% chance of having an uncertain significant variant or what have you, and knowing what to do with that. And so we wanted these recommendations to really walk people through to make it more accessible. Neurologists, at the top of that list, more accessible for how to go about this, what to include, what to talk about, to hopefully demystify it. And then I think it's catching on. I mean, I think the numbers of tests that we're seeing being done at the free testing organizations offering free testing tells us that most ALS patients are now getting offered genetic testing, and many are taking advantage of that. So I think it is becoming standard of care in this, and these guidelines hopefully will keep that in perpetuity.
Excellent, thank you. And another question that I have is, what do you see as some of the disadvantages or risks that comes with genetic testing?
That's really a personal assessment, but in terms of what I've seen, I think some individuals are a little bit hesitant to kind of confront the risk or the possibility that their condition could have a genetic basis. So there's a little bit of fear or anxiety of what might happen if we actually do find a genetic cause. But we know from our research that patients who've had a positive result actually had the most benefit and really valued the genetic test the most. So that's something that we know, like on the back end, from patients that have actually had testing. For me, I think one of the risks is that possible outcome of an uncertain results. And Matt just mentioned this, and that is something that I think, again, many persons, whether it's on the patient side or the physician side, are not prepared to get a genetic result back that says uncertain. What do you do with that? What does that mean? So to me, that's one of the important risks that exist. But we can mitigate that by pre-test education. If we know that's a possibility, if we know what our options might be on the back end, it may not be so unexpected and negative when it happens. But these days, with the approval of a gene-targeted therapy for ALS, I think some patients actually undertake testing hoping to get a positive result, and then they don't. So that's a potential downside too. If you really are expecting this to be a gateway to a targeted treatment, then it's not going to be for the majority of patients at this time. Of course, that could change in the future, but those are just a couple of considerations. But on the patient side, there's many different considerations, and it's important to try to identify those and talk through them on the front ends.
And I'll add one other, it's not really a disadvantage, it's a challenge. And that is that our genetic understanding is in constant evolution. I mean, there are some things that we learn by genetic testing that are hard and fast. Like we know, the mutation X in gene Y causes ALS because we've seen it in 100 different families. But for some other genes, the evidence is in flux, and some genes that were thought to cause ALS pretty reliably just 10 years ago, now there have been additional studies that have shown that those genes don't cause ALS. Maybe they increase risk a tiny bit, maybe they don't even increase risk. And so there are some circumstances where people have gotten genetic information back, kind of incorporated it into their family story, like what everybody knows or thinks they know, and that has changed. And so maybe there are situations where people will learn some genetic information that changes over time. And so I think the challenge that I'm referring to is that we need a way of reevaluating mutations and variants in individual genes on a pretty regular basis. And so, I think the way we do that is twofold. One, we ask laboratories to go back and reevaluate mutations and to send out updated reports when the interpretation of a particular mutation has changed. And then I think the other way that, that even people living with ALS can approach that is to continue to ask and say, okay, doc, I know that the last time I was here, you said this mutation was likely the cause of my ALS. Is that still the case? Has the understanding changed? Do we need to go back and reevaluate that at some point just to make sure that we have all of the information that's accurate and up to date? So that's another kind of side challenge when something is found, to kind of reevaluate it on a semi-regular basis to make sure that we still know what we think we know and can adjust.
And the last question I have, I think one of the challenges is with the disease like ALS is that a lot of people who are diagnosed don't necessarily live or can access an ALS center of excellence. And that would be like deserts of care, for example, people who may be in the middle of the country and are seeing a neurologist, for example, that might have never even seen an ALS patient before. And so to really get genetic testing sort of out in the forefront, if you're not going to a major center, what would you tell people who want to get tested? Where do they go? Where do they find the resources? What's available to them that might not necessarily be right in the town that they live, but how can they then at least find a way to speak to a genetic counselor, considering having genetic testing when they don't really live in an area where there's that accessibility? Because we do get that question a lot from people in the community, and it is important that people know what resources are available and just to learn about genetic testing in general.
Yeah, well, until maybe 2 years ago, that was a really big challenge. Now there's at least one option that I can mention, and that's a telehealth company called Synapticure. And Synapticure provides ALS care by telehealth to most states. I haven't talked to them recently to kind of know what all of the intricacies are there, but to many places. And they do have some excellent genetic counseling resources and genetic counselors who can guide people through testing. So that would be the first place I would say if you can't get to an academic medical center with an ALS clinic, that would be one relatively straightforward option.
Okay. Well, thank you. Paula, I'll turn it over to you.
Thank you so much, Lori. So this study does a great job outlining guideline recommendations for education and informed consent involving the benefits and risks. My question is concerning recommendations 17 regarding the pre-testing and recommendations 20 to 22 for the post-test counseling. Now, I agree with the points surrounding discussion of the potential impacts. However, this information can often be triggering, especially for people affected by the familial version of ALS. So why isn't psychological programming that might include stuff like cognitive behavioral therapy, reframing coping skills, survival skills, and the building and supporting of a support network? So weren't these recommendations also included for the entire family, or was it even considered?
Well, we sought to, in our literature search, we sought to identify studies that provided data on best practices in genetic counseling. And I don't recall that we identified any study that examines the application of cognitive behavior therapy or other specific psychological therapies in this population. So it's not to say those services are not useful. They probably are, but there's currently no evidence that supports that recommendation. So again, this is an area that we would like to bring attention to and hopefully study and develop some evidence, because this is one of the many areas where we just don't have any evidence and we're relying on expert opinions. So that's one aspect, and this is something that we need to study to be able to make an evidence-based recommendation. Secondly, genetic counselors, and I think many ALS physicians are certainly aware of the various psychosocial dynamics that can exist in families who are affected by multiple generations of individuals who've had ALS. And we are aware that these other services exist and do not hesitate to make referrals when appropriate. And some families will follow up on those referrals and be interested, and some families are not. But ALS physicians tend to be used to having these difficult conversations, and genetic counselors are certainly used to it and trained to do it. So I'm hopeful that patients who need those services are finding the way to them. But again, it would help if we had more evidence.
Thank you. So my next question involves the actual genetic testing for younger people. So thanks to Atlas and the Valor trials for tofersen, we are discovering that gene carriers with SOD1 may be starting to demonstrate symptoms as young as 19, and they're actually being tested as being symptomatic at 21. So how would you recommend, or how would these recommendations support care providers in dealing with teenagers and their parents who might be interested in genetic testing?
So our guidelines focused on testing individuals who already are manifesting symptoms of ALS, and did not delve into all of the different aspects that need to be taken into consideration for counseling and testing people who do not yet have symptoms, the pre-symptomatic or asymptomatic group, depending on your terminology. And I think this is a very important aspect that needs to be addressed. And we're generating some of the data for that in our ALS Families project here at Columbia in collaboration with the DIALS network project at Mass General and Washington University. And soon we'll be rolling pre-symptomatic options out to 34 sites across the US through what we're calling Prevent ALS, which is part of an NIH-sponsored study called All ALS. So if that wasn't enough little acronyms and study names for you, I can probably give you some more. But within those studies, we're beginning to ask those questions. How do people hear the news best? What is the most psychologically anxiety-provoking? What kinds of resources are necessary? And we have surveys that are built into this initial launches so that we can start to generate some of the evidence that Jennifer was referring to that would help us formulate those next recommendations that would take on special populations like teenagers or kids or people who are at risk for, Gene X or Gene Y. So stay tuned because we're working on that. We know it's important and are tackling it.
So given that there currently isn't recommendations, how might you change your recommendations to support caregivers in dealing with teenagers and their families interested in this genetic testing?
So I don't know that we would change these recommendations. We would maybe spend more time and sensitivity around a genetic concept called the prospect of an unfettered future, or the promise of an unfettered future, which is something that we have long held, which is that you don't want kids as they're growing up to be shackled with the knowledge that this disease might confront them one day if there's not yet a therapy for this drug, for this particular disease. Obviously, that's changing now with tofersen. Earlier starting the medication, maybe even in the pre-symptomatic phase, may be beneficial and prevent disease or keep it minimized. So we'll have to re-ask those questions. At what point does the shift, and now there is enough of a treatment that it will counteract the negative psychological impacts of finding out that you're at risk for ALS when you're a teenager and just developing your sense of self and still have the world as your oyster, type of perspective. So I'm not sure exactly how, but it's a super important point to address. I'm guessing it won't be a one size fits all type of answer. And so we'll have to kind of know the whole range of what people need and feel supported by in that space.
Excellent, thank you. I'll pass it back to you, Jen.
Thank you. Really great questions. And I just have a couple just from families, and I've heard this a couple of times, maybe a relative, a parent, a grandparent, or whatever, passed away when their child, who is now adult age, was too young to really be in any conversations about the fact that there's this, potential gene running through the family. And I know it's very, very difficult for them to try to figure out how to now bring this up as they are, you know, mid-20s and embarking on their own lives and families. Do you have any, you know, insight as to how do you start that conversation?
Sure, that's a great question, and this is something that many many families grapple with. So that's the first thing to know, is that it is hard, and it's normal to feel overwhelmed and kind of burdened by not knowing how to approach this. It does depend on the age of the family member that you're hoping to inform or enlighten. And as Matt said, there is no one answer, at least not until we get some evidence from studying, you know, these situations. But I can, you know, make some suggestions on things to avoid. And one is avoid concealing the truth. Avoid creating an atmosphere where the child or the young adult does not feel safe to ask questions. And it's very easy for families to do that by avoiding the topic and not discussing it. Very young children can pick up on that and realize that a topic is taboo, and then develop their own theories and potentially fears about what actually might be going on. So that's something to avoid. And in order to avoid that kind of, you know, taboo topic, you know, vibe from developing, it might be best to talk openly and say, let's look at family photos. Let's talk about all your grandparents and what they were like, and what happened to them in terms of their health histories. So having open conversations makes things easier down the road, but you don't always necessarily have the foreknowledge to prepare. So, you know, the bottom line could be, you know, telling a 12-year-old who's asking a lot of questions, more or less the whole story, or it could be something as simple as, you know, writing a letter when that person turns 18, or if the person's 25, writing a letter. I've seen some beautiful letters that family members have written to their children, and others, kind of breaking the news and giving information about this. So there's no one right answer, but I think it's better to try to be open about the conversations if possible, and to know that there's help. Genetic counselors can help, therapists can help, and it's not easy, so don't feel that you have to go it alone.
Thank you. That's really helpful, because I obviously, you know, everybody's level of coping is different. Everybody can process something differently. Everyone knows their own child, but we're also in this world where, you know, when I grew up, I had a different type of medical condition, but there was no Googling. There was no, the ability to look things up didn't exist. I only knew what my parents told me. And that was the most important thing, because you're getting it from someone who you trust and who is getting their information from someone that they trusted. And now it's like we have this whole big world of, you know, Google and everything. And so kids, I've heard from several parents that, you know, after a parent dies, they some of them are manifesting actual symptoms that are stemming from anxiety. There's actually not a mutation in their family, but they're so overwhelmed by it. So I think, you know, it goes beyond just, you know, breaking the news. It's knowing your person and knowing.
Right. Yeah. So I guess in your example, I was kind of assuming that we were dealing with a situation where there were a known genetic form of ALS. And just to add on to what I said previously, I think it's also important to express some hope and optimism for the future. And as Matt said, you know, we could be, you know, by the time these kids are old enough to, you know, have a higher risk of getting symptoms, we may be much more able to treat ALS. And even today, we can have technologies to enable couples who are at risk to not pass on a genetic form of ALS. So those life events are, you know, serve as kind of a deadline. Like we, you know, if you have a young person who's thinking about having children, of course, we want them to know that there's an option for them, that if their ALS and the family has had a genetic cause identified, they have the power through IVF and reproductive technologies to prevent from passing that on. It costs money, of course, but this is something that has been really valuable to many families.
That's fantastic. The other question I had is around the patient portals. Obviously, not long after you have a blood test, it pops up in your gateway, your MyChart, whatever it's called. Is that the case for the genetic testing as well, or are those sort of intercepted? And
Yeah, so the law actually doesn't give us much opportunity to prevent auto release of genetic testing results. It's mandated, and even if you were able to prevent it at the level of your own electronic medical record, the testing companies are also obligated to release it to patients on demand. And so, the way that we've dealt with that as a genetics community is to just be faster. So, we all have the genetic testing companies programmed that when a result is released, we get an email. And whatever I'm doing when that email comes through, I drop it and I look and I find out whether there's anything positive. If there is, then I make time that afternoon to try to get in touch with the patient to give them the heads up so that there isn't a surprise. If it's negative, I cut myself a little more slack, but still try to get back to people as quickly as possible.
Yeah.
But it is an issue. I don't think we want to go back to the days where you had to, bludgeon your doctor's office into sending the records or giving you access to the reports. Like, everyone should be able to see their own health history as quickly as possible in real time when doable. But this is one area where we have to work hard to prevent people from seeing information that they weren't ready for. And it's not that we're being paternalistic and want to protect people from it. We just want to be able to frame it, remind everyone, what we talked about during the pre-test counseling, and then really to be able to provide support as people are learning this news. So it's not like we feel like people need to be protected from their genetic information. It's that we want them to be supported as they're learning what could be really stressful.
Right. Thank you. That's really helpful. One other quick question I had, I know that one of the big fears of going through the testing process is actually, obviously rather, how it could impact health insurance and things like that. And, privacy towards that. Is that a real fear, or is that something that, steps need to be taken before the testing is done?
For persons who are already affected with ALS, then we don't anticipate that they would have any discrimination for their own healthcare. And in other words, their insurance company is already aware that they have ALS, and it's not really considered much of an issue for individuals who are actually affected. Now, for pre-symptomatic testing or asymptomatic testing, which is where, someone might be at risk for having a genetic form of ALS, but they currently don't have symptoms, then these concerns become more real. And currently there's federal legislation that protects against employment discrimination and group health insurance. It doesn't cover, small health insurance that's in a small business. It doesn't cover life insurance, disability insurance, or long-term care insurance. So these types of legal and financial risks are something that genetic counselors discuss with patients who are considering pre-symptomatic testing. And it's one reason why this is not something that should just be ordered on the fly. We want people to know and hear about all of these things and have the opportunity to line up those insurances if that's something that they want to do. So it's a little bit nuanced, and it's also likely to change in the future. So this is, again, a conversation that can really be facilitated with a genetic counselor or a ALS physician who has experience in pre-symptomatic testing.
And I would also just point out that the laws need to change and be updated to provide stronger protections. Many countries in Europe have far stronger protections based on genetic information. And so, the Muscular Dystrophy Association and ALS United and the ALS Association are all, using some of their advocacy work in Washington, D.C. to advocate for federal laws that would be stronger and more protective. And so if you hear about those efforts, take advantage of that opportunity to write your representatives in Washington to advocate for stronger protections for genetic information.
It's a really good point. Thank you for that. Well, this has been incredible. I just want to open it up in case there are any additional questions that anyone has based on. Okay.
I have one question. I'm just curious to know, like Dr. Harms, when a patient asks you, why should I have genetic testing done? Just really briefly, what are the reasons why?
Well, I mean, for the last year, the answer has been potentially your ALS could be caused by an SOD1 variant. And then, like Paula's experience, that you could potentially have the disease slow down, stop, or maybe even reverse a little. I think a secondary effect is that if genetic testing is negative, that also informs the risk for your family members in the other direction. And so I think those kind of paired things, the possibility of a treatment and some information for future generations, are the two things that I point to most frequently.
Good to know.
Well, I know when we wrapped things up with Lauren and Lainey, one of the things we asked at the end was what was the most important takeaway you're hoping that our viewers get from this. And one of the things that they mentioned was that just by talking to a genetic counselor does not mean you have to go forward with genetic counseling, but it's an important step in understanding the process. So I ask the same to you, Dr. Harms and Jennifer. What would you like the viewers to take away?
Well, aside from all of the information about genetic testing and genetic counseling, I want the patient community to know that it wasn't just the 5 of us authors who put time and effort into developing these, but we had 34 North American experts, ALS clinicians that joined us for several hours of deliberation and calls, read advanced drafts, did all these sorts of things. And so I want to basically just emphasize how grateful we are to all the people who participated in making that happen. And I hope that also encourages everyone that the ALS clinician community is really behind supporting people through their diagnostic and genetic testing odyssey in ALS. And I can't think of anyone we asked to join that panel who said no, unless they were on maternity leave or on vacation during the times we were meeting. Like, people were really enthusiastic to help on this front. And so I just wanted to make sure we gave a shout out to them, and hopefully people living with ALS on this call will be encouraged by how dedicated these clinicians were to helping out with this project.
Great. I can't thank you all enough. This has been really enlightening and really a fantastic way to delve into these guidelines, to have our panelists here and to be asking the questions that are really from the genuine ALS community. So I thank you all so much. I know you all wear a lot of different hats aside from just the one line under your name, and I know how busy you are. So we're just so grateful for all of your time, and we can't thank you enough. So until next time, I believe NEALS is going to be doing a separate webinar on genetic testing. We look forward to that. That will be next month. Again, thank you all so very much.
Thank
Thanks
you.
for having
welcome.
us.
Bye.
Thank you.